All what I'm going to tell about the capsular tension rings, it's related to 10 years experience with the same brand and materials. So you will find some things I'm showing in the presentations are not exactly academical like to be found in the books. Um, Capsular tension rings, we can classify them depending on the cross-section area. Um, you've got the round ones, which are not really round, they are oval. These are the regular ones, or the capsular tension rings, the CTRs known by almost everyone. And then we've got the what we call the square edge and the square cross-section capsular tension rings, which are not really square, it's rectangular. And you can find with this shape or with this cross-section from AGL and from Morture. I don't know if you see my arrow, my pointing arrow. The problem with the Morture CTR is that the height, it's 0.7 millimeters, 700 microns. It's too high. Then afterwards, we'll talk about that. The AGL square section or rectangular cross section CTRs have 0.4 millimeters height. Its thickness is 0.16, and you can find diameters 10, 11, 12, 13, and 14 millimeters each. When you are planning to select this kind of rings, you will first choose them because the material which are made of, it's PMMA, it's polymethyl methacrylato. This is a very resistant and rigid material, which is flexible enough for the implantation, but produces this sort of spring effect against the equator zone of the capsular bag. And they are sterilized in ethylene oxide. For the models, you will find there are the AC00 and the ACS, the S for square 00. And then it's the number 1002, 1102, 1202, 1302, 1402. This means the diameter in millimeters and the 2 millimeters reduction that offers the closed diameter, because this is the open diameter. It's, for example, 13 millimeters. It's the open diameter, and with the ring it's closed, it's 11 millimeters. So you will find, for example, the 1311, it's the AC 1302. And if it's preloaded, you can find the version with the injector. It's you have to add to the code the PL, preloaded. So if you want the round or oval ones, AC. If you want the square section or rectangular, it's the ACS. Okay, what are the indications to use a CTR? The classical indications, which are undisputed because nobody is going to question the indication for this pathologies. It's any zonal weakness or degeneration, like pseudoexfoliation. Doesn't matter if you already get in the pre-op, if you see in the pre-op or during the surgery, if you notice any sonoral weakness, you must put a capsular tension ring in this condition. Cases of sonular lysis, like for example, Marfan syndrome, if you have a sonular lysis smaller than 50%, then you can solve it by uh, implanting the right size of a capsular tension ring. Traumatic cataract doesn't matter if you see or not any damage in the sonul, you must assume there's a problem or there's going to be a problem in the sonul. So it's better to implant the capsular tension ring. Uh, Conditions in which you presume there's going to be an aggressive capsular retraction, like in uveitis and children cataracts. And of course, unstable capsular bags. For example, eyes with prior vitrectomy. Um, Many of the cataract surgeons have already done a cataract surgery in a prior vitrectomized eye, and you can see intraoperatively that the capsular bag is absolutely unstable and flies and moves freely, mostly the posterior capsule. So by adding a capsular tension ring, you stabilize the capsular bag. So this is the undisputed indications. But then you've got what it's called the relative indications. But are they really relative? For example, first case, enhancing premium centering. Uh, if you um, make your capsular bag regular, then the centering of the lens, it's in the IOL, it's implanted in a circled bag, which provides in long term, doesn't matter what happens with a capsular bag, the retraction, if it's not even from all of the sides of the bags of the bag, um, it won't decenter the lens. So it enhances the premium centering. And this is important regarding the premium lenses. That's why I use the word premium, because in monofocal lenses, you can reach almost 1 millimeter decentering and you will find almost no symptoms and no visual reduction. So uh, this is very important in premium lens implantation. Then to, to have a stable refractive result, ELP means effective lens position. When you implant an intraocular lens inside the capsular bag, you assume the lens is going to stay exactly at the equator of the capsular bag. But sometimes you can find deeper capsular bags, like in myopia, or the effect of scarring and retraction of the capsular bag can put your lens in another position differently to the equator of the bag. So this effective lens position, which is used and calculated in many modern formulas for IOL power calculation for cataract surgery, implanting a ring for these premium lenses improves your results, your refractive results in the post-op. The expected result, it adds a little bit of security and precision in the IOL calculation because you ensure yourself the lens is staying at the ELP. Another benefit, but I wouldn't say I would implant a capsular tension ring just to delay the posterior capsular pacification, because in the end, all the eyes are going to have the posterior capsular pacification. But it also brings a delayed appearance of this scarring and fibrosis of the posterior capsule, not needing to do anything in the immediate post-operative period. Then another indication, which is I also think it's not relative. It's to prevent the ACCS, anterior capsule contraction syndrome, or also called capsular phimosis. Like in this picture, uh, some cases, and you cannot um, predict before doing the procedure that that capsule is going to react in that way. But I've seen many cases where the anterior capsule shrinks that much that decenters the lens, tilts the lens, and leaves the capsular bag fibrotic and uneven. And like in this case, you cannot recover it because this with our diffractive lens, like in this picture, it's very difficult to provide a new centering of this lens if you don't have because you didn't put a capsular tension ring. So in the fibrotic capsular bag, it's not possible. Once this has happened, you cannot do anything. So this is again prevention. Another prevention is the nightmare prevention, because if you have a difficult IOL calculation in a premium, mostly in a premium lens, because if it's not a premium lens and it's a white cataract, whatever you put and whatever the post-op refraction is, the patient may not complain. But if you are doing premium surgery, then you have to ensure yourself you won't have a big a large refractive error in the post-op. But if you have it and you implanted a CTR during the surgery, then I can ensure this from my experience, you can do an uneventful explantation and lens replacement even 1 year after surgery without any complication. And this is provided by the implantation of the CTR during the cataract surgery, which takes just a couple of seconds. And also, it's not an expensive device considering the amount of problems you can get rid of and prevent just by implanting it. And then I wrote here the strategic premium service, because this strategic premium service, you may find patients. Luckily, if you do a good patient selection prior to the premium implantation, uh, then it's reduced by, you can find regularly in common surgeons, common cataract refractive surgeons, between 1 and 3% of discomfort in the post-op because of inadaptation to the multifocality of the lens, the system of the lens, halos or glare. So if the patient is really intolerant to the symptoms, you can also do an explantation and lens replacement even 1 year after surgery. So you need not to hurry up if the patient in the immediate post-op it's not happy. It may happen that you implant a multifocal lens, and in the first 1, 3, 4, 5, 6 months, the patient is not happy and does not adapt to that vision. So you start thinking of replacing the lens for another one, maybe a monofocal or another system of multifocality. And you you may know this by your own experience that some of these patients uh, get adapted. They they just realize what this artificial visual system and focusing with a multifocal lens it's about, and they stop having the problems. So you may wait even a year to plan an explantation, and this is one of the biggest benefits I find uh, for the CTR implantation. So during this presentation, I'm going to center my speech on enhancing the centering, the stable result, the refractive result within time, because many of you may notice that after implanting a multifocal lens, your autorefractor in the beginning is almost zero, and a year after, it's minus 0.75 with astigmatism. This is because the capsular bag is shrinking unevenly, and the lens is getting slightly decentered, and your autorefractor is measuring the lens through the side. Well, the nightmare prevention and the strategic premium service. So, um, what can we say about the premium centering? What can we talk about? What can I tell you about uh, the centering of the lens? So, first question is, where does the IOL rest after surgery? Do you really think the IOL remains in the place you left it at the moment you ended the surgery? So you say, uneventful surgery, everything went perfect. I leave my lens in this position. Do you really believe your lens is going to remain there forever, even in the immediate post op? Well, my answer is no. And the lens tends to center and mm, search for its uh, most comfortable position depending on how the capsular bag is and the dimensions. Does the centering depend on my skills? If I am a more skillful surgeon than the other, my lenses are going to be better centered than yours. That's false. Again, it doesn't depend on your ability to center the lens. You center the lens with a corneal reflex at the end of the surgery, and after the surgery, the lens has moved because the capsular bag, it's not perfectly circular. But if you add a capsular tension ring, you make it circular. So the lens will center with the circle of the capsular tension bag, the capsular bag. Uh, do I center the IOL? No, the IOL centers itself. Does the IOL remain where I leave it? No, again. Does the capsular bag size has any influence? Yes. Smaller capsular bags have less problems, and larger capsular bags, like in huge myopias, then the uh, IOL floats inside the capsular bag after you implant it. So it will stay at the position it wants after the capsular bag starts shrinking. So, in order to make the same with every implantation, so you can follow your results by implanting the CTR, you ensure yourself this lens is going to remain at the ELP, effective lens position. Shall I center the lens with the IOL with the dilated pupil? Of course, in surgery, you've had the pupil dilated. Where are you aiming to center your lens? You cannot tell anyone you're centering your lens with a dilated pupil, because we all know dilated pupils have not the same center of the undilated pupil. So, shall I center my IOL with the corneal reflex? Okay, that sounds much better. You ask the patient to look at the light, and you see this Purkinje reflex, and you center your lens there. But will the lens remain at that position? Who knows? Does my rexis have any influence? Okay, this is this is pretty a good point. Uh, Smaller rexis tend to make the IOL inside the bag less, reduces the mobility of the lens, mostly mobility and rotation, like in cases of toric lenses. And large rexis allows the lens to move slightly more, but larger rexis produces less um, uh, bag contraction and fibrosis. So you have to search for the balance. My advice, if the lens is not toric, then I tend to do larger rexes. If the lens is toric, I tend to do smaller rexes, at least an amount of rexes that it's capable of covering the lens optics, the IOL optics. If the femtorex is useful, where you can do it precisely in size, but again, if anyone has worked with femtophaco machines, any of them, you cannot you center the rexes with the dilated pupil. Again, you're not centering the uh, rexes with a white to white or with a capsular bag. So it's difficult to say that the centering of the rexes gets any influence in the final outcome. And does the material of the lens have any influence? Yes, in centering, because hydrophilic material tend to produce more aggressive shrinkage of the capsular bag. So if you can choose the hydrophobic materials of hydrophobic coating. Also, the platform of the lens has some influence, because plate lenses, depending on the thickness and material, uh, you can find different outcomes. But if you implant CTR, you don't have these problems. So this is just a reminder. We'll do a quick reminder. When you are at surgery, you have the first reflex. This is the reflex on the cornea. The patient is fixating his vision with the light of the microscope, and you assume this is the visual axis. Then you have the center of the non-dilated pupil, the geometric center of the non-dilated pupil. This not necessarily matches with the visual axis. And the distance between the visual axis and the center of the non-dilated pupil is the kappa angle. And on the corneal surface, we can measure it in millimeters. Our machines, our measuring machines, biometers and topographers, do it automatically. And then the third consideration, you have the geometric center of the white to white. And this point not necessarily matches with this geometric center of the pupil and with the visual axis. And the angle between the visual axis and this geometric center of the white to white, it's the alpha angle. The alpha angle, it's the important stuff here, because we are going to pay attention to the alpha angle in order to know if we are capable. It's one of the issues we tend to pay too much attention for the post-op results with premium lenses. So this is a Pentacam screen, and you can see here the centering of the white to white in the X axis and the Y axis. And here you've got it. It's representation, and you can see it in the Pentacam. Also, you have it in the IOL Master biometers. Always check that the white to white measurement is right, the automatic measurement. And this is an image from the eye trace, and always pay attention to the alpha angle. So we are going to plan to put a CTR, and now we know the lens is, the IOL is going to center get centered with the capsular bag. So if the alpha angle is small, sorry for this, it's in Spanish, but I didn't have this picture in English. If the alpha angle is small, you ensure that the distance between the visual axis and where the lens is going to get centered, it's not so big. So in the case of mostly diffractive lenses, you ensure yourself that the center of the lens and the center of the visual axis have higher chances of be aligned. And this will provide your patient with happiness because of good visual quality. On the other hand, if your kappa angle is larger, bigger, then you may be at the risk of having centered the lens with the capsular bag, but the visual axis could pass through the edge or through another area of the diffractive lens, producing dysphotopsia and high order aberrations, and thus having an unhappy patient. Always pay attention to kappa angles larger than 0.5 millimeters. Always pay attention. But best advice in this case is get to know your machine and how does your machine calculates it, and the result it gives you. Well, this is the important issue in selecting the size of the capsular tension ring. First, we need to know how big the capsular bag is, which is the size. So if you start doing a research in old books, you will find that the first estimation of the capsular bag size was made by Johann Gottfried Sinn in year 1755. And the following finding of a measurement of the capsular bag was done in 1983, almost 250 years later, by Hans Reinhard Koch. This doctor is still alive, and this study was published in a genetics book, not in an ophthalmologist book. So it's crazy to find something in the old times. And now at the modern times, it's our machines. We skip from the science directly into the industry. So we have the white-to-white measurement, and this is an estimation. Why is an estimation? Because the white-to-white ends up here, the measurement, where the cornea stops having transparency. But the capsular bag reaches this area. It's wider, it's bigger, larger than the white-to-white. So the white-to-white gives you an approximation of the size. Of course, the approximation is smaller than the real size of the capsular bag. So knowing this, I can guess that I'm going to choose a CTR slightly larger than the white-to-white. Also, some optometrists have done a study on the white-to-white, and there's a daily variation on the measurement. So this is not because the anatomy changes, it's because the machines are not that precise. So again, white-to-white is an estimation. It's not a perfect measurement of the size of the bag. Then you must know your machine. This is the best advice I can give you. This is a study which has been the base stone for the new topographers, which do more than one thing, like measuring white to white, estimating the anterior chamber depth, and all the other measurements, like at least five. And um, this study shows that the database was done in the beginning uh, based on this study. So the estimation of the mean white to white was done in almost 5,000 cases. But if you read the study, it's the mean white to white from a population of Iran and people between 40 and 64 years. So if your patient has an ethnicity different from this, and it's outside this range of age, then you may find some differences. So mostly in the statistic measurements. So the other advice is know your machine and know what your machine is telling you and know what your machine is saying about the statistics. When it marks you a patient outside of the range or outside of the uh, to standard deviation from the mean value, what is the mean value and what is considered a mean value, depending on where the study was done. So, for example, in my environment in Spain, I don't have Iranian people. So, uh, basing my measurements on this study for sure will bring some differences. So, pay attention to the ethnicity of your patient's population. So, okay, I'm going to choose the capsular tension ring. How do I know if I chose correctly the size? And I know that because if I chose the right size for the CTR, then the CTR is doing pressure against the equator of the capsular bag. So that distension of the capsular bag at the equator, at the ELP, reduces the capsular complex weight because you are um, holding the capsular bag against the equator. So you are giving more strength to the sonule. Then reduces the bag dance, the donesis, like you don't have any phacodonesis in the post-stop. Uh, Also enhances the bag by stretching it, like in the case of large myopias and large um, capsular bags where the posterior capsule is floating, and reduces tilting. Of course, if you have an anatomic anomaly and uh, the tilting could exist the same, but by placing the CTR, you reduce it. And later, I will show you what's the whiplash sign during surgery. So you'll know if the uh, CTR has the right size because you notice like a whiplash when you implant it. Otherwise, if you put a smaller one, you do all the opposite effect. Why? Because the capsular tension ring uh, adds weight to the capsular bag and does not stretch the capsular bag and does not strengthen the sonule. So this is the theory. The theory of our goal by implanting the lens. This is what we want to achieve. The CTR and the lens inside are not overlapping the CTR. So in a cross section of the capsular bag, you should have the CTR, and then in the haptics of the IOL and the optic of the IOL. And this is another thing. which you should ask your IOL provider. This is not regularly sent. It's not information regularly sent. How high the haptics of my single piece IOL is, because this is the standard one, I think, from Johnson and Johnson and Alcon, which are the most used. But some of them are thinner and some of them are thicker. So in order not to have disparity, you need to know this. And this is the example of the Morcher ring, which is too big and would keep the bag so open that the intraocular lens will keep on moving. And this is to show you that by placing the CTI in the right place, you do the stretching against the zonual area, against the equator of the eye. Okay, let's select the ring. We first estimate the bag size through the white to white. So for white to white between 10 and almost 11 millimeters, I would choose a 12 diameter ring. Pay attention to this. The ring diameter, the open ring diameter is 12 and the closed ring diameter is 10. So if the capsular bag is 10, then with a 12-10, the ring will remain almost closed. And with an 10.5 bag, white to white, you will have like a stretching of the, you will still have a stretching of the capsule. And with an almost 11, you will still have 1 millimeter spring effect on the capsular bag. So always choose a larger one. This measurement, the white to white, should never be smaller than the closed diameter. Otherwise, the endings of the capsular tension ring would overlap one to each other. And this is the most commonly used, the 13 millimeter 1311 for bags between 11 and almost 12, and above 12 I choose the 1412 ring. Next step, know the statistics of your patient's ethnicity. This is a useful tip for stocking rings, because if you're going to start using it, as I do in every single surgery, you want to have a stock. So the most used ones in my environment is the 30 millimeter rings, square and oval. And but you need to know the ethnicity of your patients and what this would be. I think there's not going to be much change. Third issue, know your IOL dimensions, shape, and characteristics. For example, I choose the square section rings for every single one-piece IOL I implant. Of course, I always use C-loop implants, one piece, and so I choose this square section. If I can, I always choose the square section, excepting for cases in which I'm going to implant a three-piece IOL with polypropylene haptics. They are very thin. I don't want this lens to dance inside the distended capsular bag, so I choose the thinner ring. Also in plate IOLs, only if I can fit a 13 millimeter ring, and I'm going to explain this later. Toric lenses, depending on the sort of the lens, you will get your experience, but some of them, if you implant them with a square section ring, that you may experience slightly more incidence of rotation of the toric lens because the capsules are not fixing immediately in the post-op the lens, so it may rotate. And for rexis fixated IOLs like the Femtis lens, uh, it's also advisable to put, I don't know if you know the shape of these lenses, but um, it's also advisable to implant a capsular tension ring because the part of the lens that goes inside the bag, it's thin and the material is very soft. And it's also due to uh, capsular contraction. So you may not get a decentering respect to the rexes, but yes, you're going to have a capsular shrinking. This is what we want to avoid. And while the capsular bag shrinks, then the anatomy and the stress on the sonule grows. So it's not a surprise that maybe after some time after surgery, you find a sonal problem because the shrinking of the capsular bag produces sonal stretching. Okay, why do I use round and 13 millimeter rings in plate um, lenses? First of all, to prevent the nightmare of lens problems. I don't know if in Singapore you had this problem, but here in Spain we had an epidemic of IOL opacification. And when this kind of lenses have no capsular tension ring, then the explantation after 7, 8 years becomes very challenging and not free from complications. So, uh, again, my advice is place, please, capsular tension ring. And why for plate lenses, it's a 13 millimeter ring? Well, the provider will tell you that the length of the lens is 11 millimeters and the width of the lens is 6 millimeters, but they will never tell you this measurement. So you have to calculate it. So thanks to Pythagoras, you can do this calculation and you will have that the lens, that the larger length of this kind of lenses is 12.5 millimeters. So at least you need a 13 millimeter ring to have it not overlapped to the lens haptic or the lens plate. So this is the reason why for plate lenses, I choose the 13 millimeter round because as this plate is too thin, I don't want again the lens to dance inside the capsular bag. Okay, now cautions during implantation, sorry. Caution number one, you may find some difficulties if you are not if you don't have any expertise in implanting CTRs, mostly the thicker ones, the square section. If you do a smaller rexis during the implantation, you may experience stretching of the rexis, and this sometimes is frightening and will bring you some stress. Usually, a continuous rexis without any notches won't ever break. I did almost 2,000 implants of CTRs, and I have never had a tear in the anterior rexis during the implantation. But just to prevent, have in mind that if you're going to implant a large CTR like a 14 millimeter, better to do a larger rexis in order to make your implantation easier. Caution number two, you may find more difficulty for the implantation if the incision it's in the anterior part of the cornea, like clear cornea, limbal, and sclerocorneal incision. The CTR is implanted through the main incision. So it depends where you do the main incision, the ease you will find to implant it. So vertical incidences are more difficult to handle the lens, and horizontal incidence of implantation goes more with the final position of the CTR. So sclerocorneal or limbal approaches to the cataract surgery are easier to implant the CTR. So the main incision height, it's important. Caution number three, you may frequently find this cogwheel sign. It's like while you are implanting the CTR, you find like stops. And it's not a matter of strength. If you start implanting a CTR and half the way you find a stop, don't do any strength. You take the CTR out and you try doing it the other way around. My preferred implantation is counterclockwise. So if you start implanting it counterclockwise and you find a stop, go back and try implanting it clockwise. If you find a stop again, you take it out and you can pass a thread through the whole of the leading haptic, and at the time you are rotating the CTR inside the bag, you pull from the thread, thus making the leading ending of the CTR jump over the bump. And the reason for this is because the equator, it's never so even, so smooth. So you may find some difficulties during the implantation. Do not worry. Final tips. Which CTRs to stock? 13 in my case, but study your patient's ethnicity and population. If you don't feel clever enough to implant it in the beginning, start doing large rexes and limbal or sclerocorneal incision. What we talked about, the height of the main incision. If you find that in the immediate post-op, your IOL is moving, so you have a pseudophacodonesis, return to surgery and implant a ring. You may implant a ring after the IOL. It's not a contraindication. With the IOL inside the bag, you can even put again a CTR if you haven't implanted in the first time. Always look at the kappa angle. Never forget the alpha angle. Always customize your implantation. This is premium service. Ensure long-term happy patients. This is one of the most important stuff in my business. I live on an island, and you can ruin immediately your reputation just by 3 to 5 patients that are spreading out. You did a mistake with their eyes. So be always careful, especially with bi and trifocal diffractive lenses. This is very important. Do you have a young patient like 40, 50 years old? Think of long-term results. This stability of the bag and lens should last us at least another 50 years. 50 years is a lot. have in mind that some manufacturers, like I showed you, could have a problem, accidental problem, and the lens may get a lot of glistening or directly opacification. And you may want to do an explantation in a future, or maybe the future ophthalmologist, like in 50 years. So if you implant the CTR, you are going to ease any kind of procedure on that lens in a potential next surgery. Remember always the explantation epidemics due to this problem. Offering an explantation for a poor result or a side effect like halos and glare, that is premium service. And one more tip. If you do the right implantation of the CTR and the right stretching of the capsular bag, never do the yak capsulotomy before the 6th month. I had an experience with this, and it was negative. When the capsular bag is still fresh and stretched, you can have, after the first shot of the capsulotomy, a tear that can get to the equator. So do not do it. Better 12 months at least for the capsulotomy if the posterior capsule gets opaque. Now I'm going to show you some short videos of implantations to make an example of what I told you lately. This is a case of a square CTR, and where I find a lot of stress on the anterior rhexis. My implantation is usually monomanual. You see, I put the ring, I do the strength in the circular fashion, and then once the ring is in, I bring my chopper. I use a non-aggressive chopper with a round end, and so I'm sure I'm not going to break the capsule. And you handle it this way. This is the normal implantation. Then I sometimes do a bimanual technique if I find there's a difficulty during the implantation. And you see here, I'm implanting the ring, the patient is moving. So I choose to do the bimanual just by adding my chopper on the paracentesis, on the left paracentesis, and not only to fix the eye, but also to help the CTR get in the rhexis and not to have such a stress in the anterior rhexis here. But as I told you, the anterior capsule is elastic, and if you have a continuous rhexis without any notch, it's extremely unlikely you will have a break or a tear in your anterior rhexis. Then this is an old video. This happened to me in the beginning, and it's very educative because you're going to see what happened. I call it the verticalization. This is a square CTR, and I couldn't manage to put it in the horizontal fashion, and I was afraid of touching the endothelium with the leading end. So I started trying bimanual maneuvers, and I found it difficult to put the initial ending of the CTR inside the bag. So I couldn't do it horizontal. And this is because the incision was very tight, and I found it difficult to do that. So now the ending was inside the bag, and now it's outside, and then outside, and now it's getting verticalized, and I'm afraid of touching the endothelium with this ending. I'm starting to get nervous. So I took a deep breath and I said, okay, I'm going to try again in another way. I'm going to use my right hand with the chopper to lead it into the capsular bag instead of with the forceps, but I was not successful as well. And I was starting to get really nervous, and I was about to decide not to implant it because I found it difficult, and my quick surgery was getting delayed. And again, the verticalization, and I said, okay, I'm going to grab it strongly, and I'm going to try it again, like using a little bit more strength when I grab the CTR, and then I could do it. And then you start doing your strength like tangential, circular strength. You push the CTR and it came in easily and with a happy ending. I used the chopper again now to push the back ending of the CTR into the capsular bag. Following video, no, this is the same one. Following video. Now, I was about the eighth or ninth surgery in the morning, and I implanted the lens, and my nurse said, "And doctor, aren't you going to put the ring?" And I forgot it. So I said, "Okay, give me the ring." So this is just to show you it's easy to implant the ring even though the lens is already inside. So I did exactly the same maneuver. Ensure the leading end of the CTI is inside the bag, and you just do the same maneuver. Here it goes inside, and you keep on doing the same maneuver. I went more carefully because, of course, this was a mistake. I should have done it the other way around. First the ring and then the lens, but you can implant it as well with no problems. Besides this is my very best preferred platform of lenses, one piece and C loop and hydrophobic. Okay, I use the chopper to push the back ending of the lens, and then you have the whiplash sign. It's slower because the lens is inside, but this whip sign tells you the size of the CTI is the right one. And then I managed to rotate the lens and put the second haptic inside the bag, and the surgery ended happily. And this is the last video. Again, I implanted the lens, and my nurse told me, "Doctor, do not forget the CTR." I said, "Oh, okay." And okay, yes, the lens was already in the bag and centered, so I added a little bit more of viscoelastic, and here comes the CTR. And just to show you, you can implant it after the lens with no problems. Just be careful, do gentle maneuvers, and follow the regular technique. There's nothing special to be done in cases like this. And the implantation, it's the same as a round or oval CTR, but with slightly more careful and gentle maneuvers, premium surgery. Premium surgery must always be done slowly. The quickest surgery you can ever do is a surgery without any complications. And in a premium surgery, you don't want any intraoperative complications. You don't want a complication at any level, but you don't want an intraoperative complication. So you never run with a premium lens. You do a quiet surgery, tranquilo, no problems. You follow the rules, you do the ABC all the time, and you will find no problems, and you'll be so satisfied with the results. You'll never go back again to do surgery without implanting the CTRs. Okay, This is it. At any request in the future, this is my um, email, and you can send me any request or doubt or question or whatever you want.